those of you that are online at the moment, we're just going to wait a couple of minutes because we had nearly 100 registered to attend this evening. So there's about 60 of you online at the moment, and I'm just going to give it another 5 minutes to let the others who are probably racing home from work to jump online.
Okay, perfect.
There's a bit of background noise there, Antonio. Are we able to shut the door?
It's 60 at the moment.
Pardon?
61 at the moment.
Yeah, we've got 61 online at the moment.
I would like to share some video. Is possible?
Okay. Ooh, that could be a bit tricky.
I can share my screen with the audience?
It can cause some problems. Well, if you want to put a video up, what we can do is we can record the session, and if you email me the video, I can upload it with the recording. It might be a bit difficult to show it through the webinar program. But if you email it to me, I can load it and share it with everybody that attends.
But it's too way to email you. Maybe I can share with you in Dropbox or similar.
Yeah.
It's okay?
We can try that. We can certainly give it a go. Yeah.
I can try to share.
Kids sound like they're having fun. Are you there, Antonio?
Yeah, I hear you.
Yeah.
Yes.
We can hear all the kids playing. It's a bit noisy with the kids. Can we shut the door or so it's a bit quieter for when you start speaking? Yep. Thank you.
Yeah, sure. Chicos. Hi Mel, I send you another link of the video.
Okay. Once for the eyes to see when that gets here, but I can do. Well, we might get started, so I'll just give a quick introduction to everybody, and then I'll hand over to you if that's okay.
Okay.
Okay, welcome everybody to tonight's webinar, the Manual Therapy in Plantar Heel Pain in Runners, presented by our visiting Professor Antonio, I'm going to hopefully pronounce this correctly, Siesta Vargas. So we're going to have hopefully a fantastic presentation for you all, and we'll do some question and answers at the end. If you have any questions along the way, could you please type it into the text box on the bottom of your screen? and that way we've got them there in writing and we can hopefully get to everybody's questions at the end. I'm hoping everybody's audio is good and that you can hear us loud and clear. And with that in mind, I'm going to hand it over to Antonio to deliver his presentation for you all. Antonio, over to you.
Hello.
Hello.
Hello. Good morning. Good night, everybody. First, I would like to ask you sorry for my English. I try to sleep my talk the most slowly I can. This is a short presentation about how combining the different the different modality to increase. Hi, Mel, did you move the presentation?
No, I haven't. Yeah, I'll see if I can override it for you. Okay, if you just tell me next, I'll flick the screen for you.
Okay. Sorry about that. Okay. But I could, but I would like to show a presentation about combining the different manual therapy, manipulations, stretching, massage, propose a new modality into the best practice of the health pain and fasciosis and plantar fasciitis in runner, and what is the best evidence and the best practice. First of all, I would like to remember the health pain is not only a mechanical health pain. Sometimes it's a neurologic, etiologic, arthritic, traumatic, or another. However, the mechanical health pain is the more prevalent. And in this slide, I would like to remember the guideline of 5 years ago, published in the Journal of Foot and Ankle Surgery. Remember, the majority of health pain has a mechanical etiology. And into the big group or big subtype is a mechanical health pain, is a very relevant into the move again. I put only the second one only.
Second one only? Oh.
But I can move the slide for myself, Mel.
Okay. Going a bit hectic there. Have you been pressing all the buttons?
Wow. I prefer move for myself. Okay.
Yep. Just press it one at a time.
But into the subtype of mechanical health pain, I would like to focus in another subtype. Is in the runners. And into this retrospective case control analysis of 13 years ago, we can find the prevalence of the plantar fasciitis is the third injuries more frequently into the runners. And we try to focus in a special mechanical health pain and a special plantar fasciitis and health pain in runner. But in the clinic, we can receive a lot of different health pain, and I would like to focus in the more prevalent and the more mechanical, and maybe in a mechanical, non-specific injury or disorder. This is a very interesting paper. You can find the 10 most common injuries into the runners. A lot of these injuries is into the lower limb. However, the plantar fasciitis is sometimes the very recurrent and overload injuries. And I would like to take a reflection about the combination into the practice of the clinic, research or clinical research, and basic research. Only for a small remember, I would like to show you this structure of or evidence, but I believe the audience is a clinical practice in a evidence-based, but always good to remember. We can separate the level of evidence in two ways. The first way is the filtered information, is maybe the systematic review with or without meta-analysis, critical appraisal topic, sometimes how evidence synthesis or critical appraisal individual articles. Maybe it's the more useful secondary document for put together all information about some idea. Sometimes maybe the guideline or the meta-analysis review is the more useful one. One research question is a good, powerful, with a good background into the literature. However, the primary document is this part is when the research is from directly to the researchers into the treatment area. The randomized control trials is the best one of the all designs into the clinical research. Sometimes we have not a correct control group or a correct usual treatment, only with a quasi-experimental trial, we don't know what is the real effect of the treatment, and we try to discuss later some tricky into the literature, and maybe this is the reason. Sometimes the conclusion of the some clinical research is not with a correct agreement with the clinical practice. Another type of study, core study, case control studies, always is a more poor design, and the conclusion must be taken with some careful. And expert opinion is not only the expert how the person, maybe it's the expert how a society meeting or panel of experts always is outside of the clinical research, but is necessary for the first framework for develop new clinical or applied research before to the big critical appraisal of the best evidence into the literature. This is a small, there's a small schematic draw about the how, what is the maybe the different stage or different level into the plantar health pain in the last guideline published 5 years ago. In this 5 years, we find a few randomized control trials more powerful. However, the recommendation in the guideline not change so much. And in the first stage, we can find different modalities of treatment, how padding, strapping, or taping, stretching exercises, OTC arc support, heel cap, shoe recommendation, oral anti-inflammatories, hand physical therapy, corticosteroid injection. All these treatment have a similar effect side. The effect side is the power of the treatment is very similar when the design of the randomized control trials is with a correct control group and a good eligibility criterion, and usually the recommendation is too similar in the guideline when we don't find conflict of interest for the treatment into the 6 weeks when the patient should be possess a chronic symptom or undergo treatment for at least 6 months prior to the consideration for the third level of treatment. But the problem is the effect size in this first stage is very similar and very small. And we try to find into the research what is the answer to the practice in the clinic. But in the practice in the clinic, we sometimes use the clinical reasoning and decide one treatment is better than the other in a different patient. But it's very difficult to develop randomized control trial. Okay, we find difference between this type of modality into the first stage. In the second stage, the guideline propose a corticosteroid injection or custom orthotics, 9 spleen, immobilization, and physical therapy. How a second stage before the chronic symptoms can go. And in the third stage, we can find the extracorporeal shock wave or fasciotomy or nerve release, how proposed in some very chronic health pain. Into the practice, this is a very big variability of treatment and with a different presentation of the symptoms, and history of evolution of the health pain. We try to reflect about how improve this proposal. In this slide, I show you 3 examples of the meta-analysis study when we combine a different randomized control trials into the Cochrane collaboration. And in this case, we can identify how the extracorporeal shock wave present some effect in a different study when compared with the sham extracorporeal shock wave, but the effect is very small, but is consistent across the trial. However, in this type of trial, we need to be careful about the maybe the industry support the design of this study, and if we read the randomized control trials with critical appraisal, we can find that the control group is a waiting list or is not the usual care, and maybe we can find the good effect size for the experimental group. In the other picture, we find in the therapeutic ultrasound, we don't find difference between the recommendation of treatment and sham treatment of the ultrasound. In the orthosis treatment, we find a small difference and inconsistent across the trial. This support the idea of the effect is correct along the different modality. However, the FSI is small and the variability of the treatment and the patient is too big, and we need to thinking how increase the effect size and how decide what is the best treatment for each patient. For introduce the manual therapy into the health pain into the runners, I would like to share with you this prospective clinical trial with 2-year follow-up is a sample of across the different modality. We can find the very easy specific self-stretching of the plantar fascia during 10 seconds per 10 sets, 3 times per day. In the first 8 weeks, when we compare with a control group of the Achilles tendon stretch, we find difference into the visual analogic scale with a significant difference into the groups after the treatment. However, when we remove the treatment 2 years later, the improvement is whole along the time in a 2-year follow-up. This is a sample published 9 years ago in journal Bone Joint Surgery, where very easy treatment produced around the 20% of reduce the pain. And this is the effect side we can find more powerful. And the treatment is very cheap, easy. However, we believe, or I believe, is not enough for all patients, but is enough for big heterogeneous group of the health pain. And maybe this is the best trial with 2-year follow-up we can find in the literature. And the control group in this case is Achilles tendon stretch. And now in the end of the presentation, we try to go to some biomechanic idea about the relationship between the Achilles tendon and plantar fascia. This is another sample published 6 years ago when in a randomized control trial compare the standard physiotherapy combination, the stretching, the mobilization, and the therapeutic ultrasound. And we read before without evidence when compared with the sham ultrasound. And in the other group, we found extracorporeal shock wave combination with stretching, in this case too, and we don't find difference. And maybe this is the only one randomized control trials. We don't find good results for with the shock wave, but the control group have stretching and mobilization is the good usual care to compare, and is not consistent with the other randomized control trial we can find in the literature, maybe with some conflict of interest. This is a very good paper of the Cleland et al. Published 6 years ago when combining the manual physical therapy and exercises versus electrophysiological physical agent and exercises. This is a very good design, but it's a multi-center randomized control trial. This is a different sites, and this design is more external validity and internal validity, and also we can find the try to put in the control group the electrophysical agent. In this case, is a iontophoresis with eyes after the iontophoresis with some small evidence how a usual care. But in the experimental group, it's the manual physical therapy combination with exercise. The exercise is in both arms, in both groups, and is a real control of the effect between group and not only the effect within group. Into this slide, we can find maybe only a 10-12% of the improvement for the manual physical therapy combination with exercise, but we compare with the same exercise with the electrophysiological agent. In this study, the changes within groups is really high, because both groups is a real experimental group. However, the effect of the manual physical therapy is enough powerful to increase the difference between groups. This is another chart, another plot into the same study about the disability, and we can find how after the treatment, 4 weeks later, we can find the improvement for the manual physical therapy group hold along the time in a 6-month follow-up. Later, I tried to show you some video into the similar of the manual therapy of these researchers used in this in this study, and I would like to share some clinical idea close to the research outcomes for to proposal the best practice into the between the clinical and the research. But before this idea, I would like to share another very good trials published in the same journal. It's the Journal Orthopedic Physical Therapy, where this research team with some Spanish colleague published effectiveness of the myofascial trigger point in manual therapy combined with a self-stretching protocol for management of the plantar heel pain. In this case, if you remember the self-stretching very easy study of 2-year follow-up, this self-stretching is included in this trial how usual care, and is a very good control group with a very good internal validity, and compare with, in this case, with a myofascial trigger point is another type of manual therapy. The first one I showed you before is about manipulation, and in this case is more focused in the soft tissue, and the myofascial trigger point of this research group is into the Travel and Simon approach, and is a pressure for 19 seconds into the active trigger point, and connective massage stretching in the tense bands. It's really interesting how the difference between groups is powerful for the myofascial trigger point when compared with the self-stretching, and in this case again the within group effect size is very big. This is congruent with the literature, and we can find the self-stretching is very good treatment. However, when compared with the myofascial trigger point, combining with the self-stretching is much better. And for my proposal is to thinking about the include into the traditional treatment different manual therapy, how manipulation, trigger myofascial trigger point, and advice of the self-stretching, combining with the another modalities into the podiatric professional. And in this idea, we developed a few years ago this randomized control trial with 4 experimental groups. Sorry, but this slide is in Spanish, but I can show you. This is 4 different arms, and the first arm is orthotics advanced, and this orthotic is a custom orthotics with the design with the best recommendation of the Spanish panel of experts into the Faculty of Health Science with podiatry lecture. This is this group combining the custom orthotics with the manual therapy. In this case, this manual therapy is a manipulation of the all lower limbs, is a myofascial trigger points, and self-stretching at home. We try to put all knowledge into the best practice into this experimental group. However, for compare what is the real effect between group and not only within group, we try to compare with this group is a only orthotic, custom orthotic without manipulation, and compare with only manual therapy, and compare with a basic orthotic. In this case, this is a placebo orthotic, but this is a not custom with only 5 millimeters of orthotic without customizer. And this is a very complicated design with 4 different groups randomized in the different sites and combining the basic orthotics and advanced orthotic from the panel of expert, advanced orthotic with the manual therapy and manual therapy alone. The idea of these 4 different subtypes is to analyze the effect within group into each group from the baseline and compare between group with a different supplementation to try to understand or translate what is the effect of the manual therapy into the orthotic treatment, combining or alone. In this study, the different research outcome is the primary research outcome, is the food health status questionnaire. Is a wonderful questionnaire to detect the changes into the different dimensions of the food health. However, measure the general health of this person in the same time, and we believe is the best outcome for this design. Here, I would like to show you preliminary results of the study. This is only with 65 patients about the dimension food pain into the primary outcome, the food health status questionnaire. And we try to put in the slide the traditional box plot. However, I changed the traditional box plot for this plot for some idea I would like to share with you. If we have a look to the plot, the same to only focus to the first column, we can find the baseline distribution. The blue group is the group with only manual therapy, and the combined treatment with the is advanced orthotics with manipulation. We can find difference between both treatment. 1 month later the treatment, we can find difference. The food pain reduced in the subgroup, in the group of the combined treatment. This is relevant into the actual literature, but we can show the combined treatment of the manual therapy with orthotics is better than the manual therapy alone. However, I would like to put the attention about the variability of the group. But if you can see in the manipulation group, we can find a big variability in the baseline. However, this concentration is better after the treatment. However, the combining group is similar variability in the baseline and is more variability after the treatment. This is a very relevant idea about maybe some patient is responder and very good responder in mean for this combined treatment, but some subgroup, some small group into the heel pain is not good responder. I try to put into this chart lines, blue lines and yellow lines, and in blue lines we can identify how one is in an up direction and another one is in a down direction. We can identify the trends of the group is correct, the combined treatment is better than the only manipulation. However, I would like to identify what is the variable of the people no responder of this type of treatment. Maybe in the future we need to think similar to other big disorder, how back pain or neck pain, when the subclassification of the different subtype or subgroup into the heel pain, we need to tailor or to prescribe different treatment for the best responder patient. In this case, in this chart, we compare in a preliminary result of the trials, we compare the basic orthotic and advanced orthotic with no difference between orthotics after the treatment. This is consistent with the literature. A lot of randomized control trials with orthotic, we don't find difference in a big group, and in this case, it's very useful to identify how some patient is no responder, is in go down line, and another is responder. Maybe the cluster of subgroups analysis with the complete sample in the future maybe can respond to identify which characteristic is the each group, responder or no responder. How measured the evidence exists, and maybe the evidence is we have a lot of modality, but we need to teach, learn, prescribe, and use the most effective technique without prejudicing the technique. No evaluate with caution. But maybe the experience in the clinic is we try to focus in a deep interview to decide what is this responder and no responder group, and into the clinic is more easy maybe to decide what is the pathway for each patient, but it's too difficult to bring this idea to the clinical research. However, in the guideline, the recommendation is very big into the modality, and maybe we need to introduce new idea about the subclassification of the heel pain and decide to what is the characteristic of the responder and non responder. For my proposal, after the combining the clinical research in a preliminary results and the clinical experience, is maybe the first stage is the symptomatic treatment and focus in the best cost effectiveness or cost utility treatment. And maybe we find different approach, maybe medication into the non-anti-inflammatory, non-steroid anti-inflammatories, into the physical agent, ultrasound or maybe electroshock is a low evidence and very critical randomized controlled trials, and taping only for very short effect, orthotic, but the custom orthotic is not more powerful than the no custom orthotic, and mobilization with movement combined with eyes maybe is the first proposal of the treatment, focus into the symptomatic treatment. But the real treatment is to try to normalization of the joint and the soft tissue, basis to the self-stretch of the plantar fascia prescribed at home, combined with the manual therapy. And into the best randomized control trial, we compare with you after the guideline, the combination of the manipulation of the all lower limb and lumbar spine too, with the myofascial trigger point and advice about the self-stretch is to good combination for normalization of the joint and soft tissue. However, we don't find into the literature a proposal of the strengthening of the muscle. And I would like to share a very new paradigm, new proposal about the stabilization of intrinsic muscle of foot and combining with a resistant training of the lower limbs. Here, we like to remember the stretching, the self-stretch of the. I try to decide my proposal for the manual therapy. I can read now the TED Jedin and then which joint I try to share now. The self stretch, my proposal is combining both the Achilles tendon and the plantar fascia. Now we find in the literature some in the first in vivo study about the relationship between the Achilles tendon and fascia and plantar. My recommendation is self-stretch 10 seconds, 10 sets, at least every morning, but in the first 8 weeks, 3 times per day. And this is the manipulation we recommend into the lower limb, but after the individual assessment. We need to practice individual assessment into each patient, and when we detect hypomobility of the joint, we practice manipulation into the hypomobility joint. Not all patients need manipulation, but all patients need prescribed of the self-stretching of the Achilles tendon and plantar fascia. I share with Mel 3 or 4 videos of the manipulation I practice into my patient. And in this case, for this slide, I put here only one frame of the video. You can find and download in the paper I showed you before, published in the journal Orthopedic or Physical Therapy. And we try to into the assessment, we explore the spine, focus in the pelvis and lumbar spine to detect into the chart assessment what is the area for manipulation. The more usual is the sacroiliac joint, and maybe the median lumbar spine, L3, L4. It's very useful into the hip assessment, looking for hypomobility with the anterior fix of the hip, and it's very useful to detect the knee is not is a hypomobility of the knee for the translation movement and knowing the angular movement. Subtalar joint and the ankle joint, we need to explore with a deep assessment. And all joint we detect is a hypomobility, we need to normalize it with the manipulation. In my case, in my experience, we have a training in the Maitland approach and osteopathy approach, and we combine a different technique into the normalize the joint. Into the foot, we practice different deep assessment for combining the different area of the midfoot and retrofoot and the anterior area of the foot to detect hypomobility area and try to normalize the joint. However, in the first step is the self-stretching at home. The second step is the deep assessment of lower limb and manipulation only the hypomobility area for each patient, but both stage of treatment is a passive treatment. And the third of the passive treatment is more clear, more close to the nervous system, central nervous system. And the myofascial treatment, we need to identify the active and latent trigger points, and we practice a 90 seconds pressure into the pressure pain threshold and measure with an algometer and hold 90 seconds to the patient release the pain and pass to the comfortable area. And we repeat 3 sets. In usual, my proposal is into the medial gastrocnemius and into the intrinsic muscle of the fascia plantar, and neuromuscular technique along the medial and lateral gastrocnemius and tibia posterior. This is part of the passive treatment, but I would like to introduce the new paradigm. This research published 2 months ago in a British Journal for Medicine, Patrick O'Mockeon. The foot core system is a new paradigm for understanding intrinsic foot muscle function. This is a replication of the proposal from Punjabi maybe 20 or 30 years ago, and combining the neural subsystem with active subsystem and passive subsystem. All treatment I recommended you about the self-stretch, manipulation, and myofascial is a passive treatment, and we need to understand that the patient go home, only the gait and the functional activity daily is the good training, but maybe some patient is not enough. And for introduce this idea, I would like to share this paper. It's a very good proposal about the neural system is a musculotendinosus receptor, how a local and global sensor, and ligamentum receptor, including the plantar fascia, and the plantar cutaneous receptor is the subsystem of the neural area, and combined with the correct passive subsystem when the ligaments, plantar fascia, and bones is a good structure with enough structure for the active subsystem, and the active subsystem is the intrinsic foot muscles, how a local stabilizers, and extrinsic foot muscles, how a global movers. This is a part of the picture of this paper, and this author proposal. We need a passive structure to reach a good functional into the foot, how prevention of the plantar fascia, and present the structure how a dome into the different arc of the foot, and we need to prepare the extrinsic muscles, and you can find here the cross area of the peroneus and posterior tibia, how moves, but support too, and the relevance of the intrinsic muscle, how training. And this author proposal, the relaxed foot core, stretch the plantar fascia without energy, and the contracted foot core produce with the maneuver the real use of the all core system of the food. Maybe this is a new paradigm in the food, but not in the human body. We need to think maybe the proposal of the people gave without shoes or minimal barefoot riding with the correct use of the medium art of the food promote the more function into the food. Maybe for the next future we need to combine them, this evaluation of the passive, active, and neural subsystem for detect responder or no responder, or maybe prepare to the muscle for the, or maybe the sensor for the real muscle function, for compensate the use into the usual life with flat shoes or hard floor or without low muscle function. Okay, but thank you. I'm sorry for my English. I hope to give you some or share with you some idea about the manual therapy. And now I have a few minutes, I think so, for the question. Thank you very much.
Does anybody have any questions? If you do, if you could just type them into the text box, and then hopefully then Antonio can answer them as best he can.
Yes. Okay, I have a question from Ted about the which joint, but I believe he right before I put another slide with the joints, and now Ted asks about will there be a video of the manipulation technique, and I send the link of my video to Mel, and you can find another video of the paper of the randomized control trial I showed to Cleland. Both videos you can find maybe a few different in the technique. My technique is more close to the mainland, to the osteopathic approach, and the other one is combining of the chiropractic and osteopathic approach, but it's focused to the mobilize the same joint, the same area.
And I'll forward that video to everybody tomorrow so that you can all view that as well.
Okay, another people, Helen and George, ask about the activity to continue for patient while they receive treatment. Yeah, but maybe if we practice ultrasound assessment and we can detect the integrity of the fascia, in my experience, I practice ultrasound assessment. And the integrity of the fascia is complete. The concept is fasciosis. Never I stop the physical activity, but never recommend start new activity. And we combine the treatment with the usual activity in sport people, and the people don't practice sport is not the best moment to start the treatment and the sport in the same time. But my recommendation always is to follow up with the same activity before your heel pain. But the fasciosis is a very long histologic problem, and we need to maybe we don't need to change the activity daily. Yeah, I received a few. Are you? It's a few questions. Okay, but I try to. Yes. Paul Bennett asks about are you using shockwave therapy in your clinic? No, in my case, in my private clinic, I don't use shockwave. I believe we have no enough evidence about the shockwave. But in the clinic of my faculty, we have in the some helping with very degenerative structure. My colleague used some time with good results, but it's a clinical knowledge. And maybe if we don't, if you find to the literature, you can find a randomized control trial, but after the clinical appraisal of the trial, we don't trust so much in these trials. But in my case, I don't use. And this is a good question, and combining with another question of the Alex from Gold Coast. He asks about the research in dry needles thrown into the extension plantar fascia. I believe the effect of the shock wave and the pulsatile or pulse very high powerful ultrasound and the dry needles is very is a mechanic effect into the tissues. And in the case of the real fasciosis with a very low answer to the treatment, the small injury into the tissue to promote the biological response. And now we are trying to identify what is the histological answer into the dry needle. And another very popular treatment in Spain is a dry needle with a galvanic agent into the needle and put a very low current to promote the healing. Maybe I have a few questions I don't read before about the strengthening exercise. I don't know this paper. The that axe is the right left. I try to looking for this, but before we design my trials, we found a few papers about the strengthening exercises of the intrinsic muscle, but the design is very poor and the effect is very poor, and we don't consider. However, we teach in the university for the health pain, but I don't practice in my experience. And I believe we need to focus the strengthening exercise in all lower limbs, in the quads, and gastrocnemius, and extrinsic muscles and intrinsic muscles without close chain of the lower limbs with a different training after the normalization. In my practice, always I try to put the manual therapy in the start with education. In this case, is advice for self-stretching and try to use the usual walking without shoot in an irregular area. and after the manipulation in the patient they need, always I prescribe prescribe a specific strengthening program focused to the lower limb. The first step is focused to prepare the resistance and endurance with low load, and after is very speed training focused to the neural system of the core system of the foot and lower limbs. And for me, I separate the foot to the limbs. Always I train in the endurance and strengthening and the speed training and functional training in the end for lower limb in all injuries of the foot. I received a few questions more. Kaya asks about how important is footwear with the plantar fasciitis. Yeah, but maybe I tried to explain before, but if we consider the core, the new paradigm of the core system, maybe the slowly introduced to the patient to the minimal barefoot gait with contact of the foot in the median area of the foot and slow promotion of the sensitive area, strength, muscle, the intrinsic muscle and extrinsic muscle of the foot, and training of the all chain, all lower limb, maybe is compensate the footwear. But I believe the excessive orthotics or foot protection maybe reduce of the real stabilization of the foot. I believe yeah. Another colleague, Peter, from Sunshine Coast, say, what is your thoughts in low level laser? Any evidence? I have no experience with the low level laser in the heel pain. I read a few papers about the small effect and significant effect when compared with the control group, but it's the same effect than the iontophoresis and in the same effect that the therapeutic ultrasound. And it's a small effect, and the trials is not very good quality, and we have not good evidence about the low laser therapy. But maybe we need more randomized control trials with a good control group and good design to know what is the real evidence. I believe the background of the laser, ultrasound, and iontophoresis, all physical agents, is a similar background about the promote healing. Maybe the effect is not enough for the big population of the heel pain. Maybe we need to decide what is not. We need to focus not only what is the best treatment. We need to focus in a sub-classification of the patient into the trials, the same of the practice into the private practice. Always in the private practice, I try to identify what is the subgroup or sub-classification of the heel pain and propose a different treatment. And for the podiatric profession, my recommendation is to think in the manual therapy and the self-stretching, how a combined treatment with the usual treatment with a good experience into the practice and to know the clinical research, but the evidence always is not the best evidence, but some treatment is a good evidence, a good recommendation into the trials, but the effect is low, and maybe the population is too big and very variability responder, and we need to identify in responder and no responder and should use a correct subclassification of the patient in the assessment. I don't know if we have more time, but it's 7:30.
Yeah, we still have a few more minutes. Yep, you're fine.
Okay. Yeah. Yeah, another person, Helen and George, asks about do you find different with outcomes or different in treatment depending of the food structure? This is a really good question. When we into my trial of 4 arms, 4 subgroups, when we identified different in the combined treatment, we are really happy. What we are thinking is the best treatment. However, when we know the no responder, the people go down in the line of the chart I showed you before. My first idea is to go to see this patient, and maybe it's hyperpronate or maybe it's cabot feet. It's the same idea of Helen asked now. But we have a lot of characteristics of the patient, of the no responder, but the sample of size is too small now to the cluster analysis. When we have a big sample, we can identify what characteristic, and maybe hyperpronate is one of these, and very short Achilles tendon is another one. We have all biomechanic and gait parameter of this patient, and maybe this is and the strengthening of the ankle maybe is another one. I need more sample, but my idea is the hyperpronate, short Achilles tendon, and very low strength into the extrinsic and intrinsic muscle and all lower limb is a good predictor of no responder. And the weight of the patient maybe is not related, but is the first one. But the strength in the force play in the biomechanic assessment is always is adjust for the weight of the patient. But we need to wait to see what happened in the big sample. I believe the whole experience we have in the private practice about the hyperpronate and very short Achilles tendon and very low strength in the knee muscles is a very good predictor of the no responder. And the treatment of the self-stretching and orthotics and some manipulation is not enough. We need to focus in detect this patient and prepare with a specific strengthening training and precision training for the functional training in the end, for the more functional activity into the feet and the lower limbs. Okay, I believe I answered all questions. I can read into the chat. I don't know, maybe sometime we received a lot of questions, but I check and I believe I answered all questions.
Are there any other questions from anybody?
Mel?
Yeah.
Yep. Are you share the video with the audience?
I'll be able to email it to everybody tomorrow. I'll email you a copy of the slides. And we'll share it that way.
Okay. But in my last slide, you can find my email address of my institution in Spain is aquesta.uma.es, or my institution in Australia in KUT. And this is my Twitter. And I would like to thank to the BMC series, and this the journal I am an editor of the exercise and health area, and I invite to all podiatric profession submission paper about the training for prevention and for treatment of the health pain. Is all call of paper is welcome. Okay.
Well, thank you everybody for attending. I hope you gained a lot out of it, and we'll see you at our next webinar.
Okay.
Thanks, Antonio.
Thank you, Mel. Thank you. Thank you very much. Bye.